Hi, I am Rasan Majalati Naval, a fourth year medical student of the Davao Medical School Foundation. Today, we are going to talk about retinoblastoma. So, what is retinoblastoma?
It is an embryonal malignancy of the retina and the most common intraocular tumor in children. A primary malignant intraocular neoplasm that arises from immature neuroepithelial cells of the developing retina or retinoblasts. Incidence. Worldwide, the incidence of retinoblastoma is recorded to be about 11 cases per million children younger than 5 years. Most develop within the first few years of life. Some are present at birth, and occasionally, they have been identified by prenatal imaging. Etiology. Retinoblastoma occurs when nerve cells in the retina develop genetic mutations. These mutations cause the cells to continue growing and multiplying when healthy cells would die. This accumulating mass of cells forms a tumor. Pathophysiology. Histologically, retinoblastoma appears as a small, round, blue cell tumor with rosette formation, or Flexner-Wintersteiner rosettes. It may arise in any of the nucleated layers of the retina and exhibit various degrees of differentiation. Retinoblastoma tumors tend to outgrow their blood supply, resulting in necrosis and calcification. Endophytic tumors arise from the inner surface of the retina and grow into the vitreous, and can also grow as tumors suspended within the vitreous itself, known as vitreous seeding. Exophytic tumors grow from the outer retinal layer and can cause retinal detachment. Diffuse infiltrating tumors grow intraretinally and remain flat. These are less common and can cause iris neovascularization. Tumors can also be both endophytic and exophytic. These tumors can also spread by direct extension to the choroid or along the optic nerve, beyond the lamina cribrosa to the central nervous system, or by hematogenous or lymphatic spread to distant sites including bone, bone marrow, and lungs. Differential diagnosis. Coats disease. This could be ruled in because it presents with leukocoria and strabismus, but can be ruled out because it has a more yellow appearance with yellow subretinal exudates compared to retinoblastoma. On fluorescein angiography, it has a more characteristic telangiectatic and dilated vessels, regions of non-perfusion, and aneurysms with leakage. Retinoblastoma has less leakage and more often shows irregular perfusion abnormalities consistent with tumor vascular patterns such as dilated vessels with non-perfusion. Abnormally dilated tortuous vessels may be associated with significant exudation, causing a mass-like lesion of lipid with associated telangiectatic neovascularization. The exudate is more yellow than white because of the presence of cholesterol. It is typically unilateral and predominantly affects boys between 6 to 8 years old. Persistent fetal vasculature, also known as persistent hyperplastic primary vitreous. This can be ruled in because it presents with leukocoria during the first few months of life. However, can be ruled out because it is typically unilateral and eyes tend to be microphthalmic. Retinal detachment is more often tractional and tent-shaped, whereas retinoblastoma retinal detachments are more likely exudative with subretinal fluid and possible seeds. Upon B-scan ultrasonography, grayscale evaluation may reveal a medium increased echogenicity band in the posterior segment of both globes, extending from the posterior surface of the lens capsule to the optic disc. Color Doppler may reveal the presence of vascularity along the entire length of the band. No calcification or mass lesion could be seen. Imaging in diagnosing retinoblastoma. B-scan ultrasonography. It will show mass dimensions as well as hyperechoic calcifications. CT scan. Retinoblastoma appears as a hyperdense lesion on CT in relation to the surrounding hypodense ocular vitreous. It is also another beneficial tool in detecting calcification, which may be seen in a non-homogeneous pattern in most large tumors or in a homogeneous pattern in smaller tumors. CT images can also be useful to detect any associated metastatic brain lesions. CT scan is now the modality of choice for diagnosis and follow-up of children with retinoblastoma due to radiation exposure. Magnetic resonance imaging. It may be beneficial in estimating the degree of differentiation of retinoblastomas, but is not as specific as CT because of its lack of sensitivity in detecting calcium. Classification of retinoblastoma. This is the intraocular classification of retinoblastoma. Group A, which is very low risk, has a retinoblastoma of less than or equal to 3 millimeters. Group B, which is low risk, has a retinoblastoma of more than 3 millimeters or macular location, which is less than or equal to 3 millimeters to foveola, a juxtapapillary location, which is less than or equal to 1.5 millimeters to disc, additional subretinal fluid, which is less than or equal to 3 millimeters from the margin. Group C, or moderate risk, has a retinoblastoma with subretinal seeds, which is less than or equal to 3 millimeters from tumor. Vitreous seeds, which is also less than or equal 3 millimeters from tumor, or both subretinal and vitreous seeds less than or equal to 3 millimeters from tumor. Group D, which is high risk, has retinoblastoma, which has subretinal seeds more than 3 millimeters from the tumor, or vitreous seeds more than 3 millimeters from the tumor, or both subretinal and vitreous seeds more than 3 millimeters from the tumor. And Group E, which is very high risk. It has extensive retinoblastoma, occupying more than 50% of the globe, or with neovascular glaucoma, opaque media from hemorrhage in anterior chamber, vitreous or subretinal space, invasion of postlaminar optic nerve, choroid of more than 2 millimeters, sclera, orbit, and anterior chamber. Treatment of retinoblastoma. Treatment depends on the size and location of the tumors. If the disease is localized to the eye or has spread either to the brain or to the rest of the body, and whether the child has hereditary or sporadic disease. The primary goal of treatment is always cure. The secondary goals include preserving vision and the eye itself, and decreasing the risk of late side effects, mainly secondary malignancy. Most unilateral disease presents with a solitary large tumor. Enucleation is performed if useful vision cannot be salvaged. With bilateral disease, chemoreduction in combination with focal therapy, which is laser photocoagulation or cryotherapy, has replaced the traditional approach of enucleation. If feasible, small tumors can be treated with focal therapy with careful follow-up for recurrence or new tumor growth. Larger tumors often respond to multi-agent chemotherapy, including carboplatin, vincristine, and etoposide given intravenously. The delivery of chemotherapy via the ophthalmic artery is becoming more common, as is delivery of intravitreal chemotherapy. If these approaches fail, external beam irradiation should be considered, although this approach may result in significant orbital deformity and increased incidence of second malignancies in patients with the germline RP1 mutations. Brachytherapy or episcleral plaque radiotherapy is an alternative with less morbidity. Enucleation may be required for unresponsive or recurrent tumors.
These are my references. And that is retinoblastoma. Thank you.